Ready? You think? Oh, hey everybody. This is Steve Cole with Ada County Paramedics, and this is my first video I'm doing for you guys. And today, to help make sure that I'm doing this all right and I'm putting out some good information, this is my friend Deary. Deary, who is my daughter's very special friend, is coming with me today to help make sure that I'm doing a good job. So, am I doing a good job? Okay. Deary's going to sit over here and she's going to watch me teach you to make sure that I'm doing what I'm supposed to. So I hope you understand. Okay, so today we're going to talk about a concept called NO DESAT. I'm going to preface this. This lecture, we're kind of flipping this out to you guys ahead of the difficult airway block training that's coming up. But we're also going to make this available as a standalone lecture that you can show your FTOs, you can come back and review, whatever the case is. Because I think this is an important concept and a very simple concept that each and every one of you guys, whether you're an EMT, advanced EMT, or medic, can use out there in your practice. So you may have heard about this. You probably just may not have associated the term NO DESAT with what we're going to talk about. And what we're talking about today is the use of high-flow nasal cannula supplemental oxygen. And you may have heard, people talking about, well, I've heard people putting on this nasal cannula instead of a non-rebreather or with a non-rebreather and running it at 15 minutes per minute. And hopefully by the time you're done with this 15 minutes, 20 minutes, so we've solved all your questions. We've answered everything and you're happy-go-lucky. So that is the objectives today, is we're going to talk about the use of high-flow oxygen via nasal cannula in the airway failure or respiratory failure setting. Now, I'm going to lead into, I'm going to throw a case study out at you. This little case study, informal case study, was a patient I actually had that beforehand I'd read the stuff on nasal cannula, NO DESAT, high flow oxygen. I was pretty much had bought into it, but hadn't seen anything that was the light bulb coming on. I'd used it a couple times previously leading up to RSI. But the RSIs I had done it on were pretty much uncomplicated. Everything went well. And when everything goes well, you don't know whether it's one particular thing over another that was the key to things going well. It was your lucky day. This case study was a situation that was pretty ominous and pretty much sold me on this idea. So, working out in a part of the county, nameless part of the county that begins with M and ends with an N, we were dispatched to an adult seizure patient, a younger guy in his 20s, 24-year-old male with a long-standing history of seizures, along with some other stuff. He lived an active life. He wasn't a bedridden gentleman, and he didn't have completely debilitating pathology, but his seizure history is pretty significant. So we're dispatched out, me and my partner, to this gentleman. We find him in a trailer park, and he's been percolating his juices in active seizure activity for about 4 hours. And this is already not a good situation. And if you think about it, you think about the increased metabolic oxygen demand, decreased acidosis, the decreased tidal volume, the hypothermia that goes along with that. That alone presents a somewhat ominous clinical picture and problematic. The reasons this guy had a seizure, basically he hadn't had his seizure medications for a number of different reasons for about 4 days. He was there with his family members who's had been watching him percolate in his own juice about 4 hours, and the most aggressive thing or the most helpful thing they had done was to stick a baby spoon, a big huge toddler plastic spoon into his mouth to keep him from biting off his tongue. I'm sure we've all heard that before. Keep him from biting off his tongue, and in the process just made a kind of a bloody mess of his oropharynx. Nothing we haven't dealt with before, but not ideal. When we assess him, he's got some rigidity of the jaw. He's tachycardic in the 130s. His SpO2 is like 82, 84, some in that range, and he's warm to touch. He's diaphoretic, he's warm to touch, and pretty obviously, while he's not paramortem, he's not in good shape either. So let me switch slides here. There we go. Okay. So as I said, his airway is somewhat dubious. His jaw's clenched. He's got some secretions and a little bit of blood mixed in. Again, he's not bleeding out in his airway, but he's got some stuff that we need to do to manage. We got to suction him. On top of this, on top of all this other stuff going on, as we're assessing him, we know several significant scars to his anterior neck over his trachea. He's had a stoma, or he's had a trach before. He's had a stoma scar. He's had some other scarring there. And when we ask his family, we're given a report that he's had prior neck and throat surgery. Now, again, this is a 24-year-old guy with a fairly decent thyromental distance and a decent oral pharyngeal opening. So all that should be fine. And the Lemon assessment is looking good. He's not obese until we hit that mark. And if you haven't had the misfortune of dealing with, trying to intubate somebody that has a history of laryngeal surgery, it really is a crapshoot. You might go in there and everything's pretty, or you might go in there and it's completely arranged out of order without knowing what it was they had to do and why they had to do it, whether it's cancer or something else or chronic aspiration or whatever. And the family was a very poor historian, so we had no idea what was going on. But combined with what we had to deal with looking at that is a big red flag. So as we're looking at him and we're assessing him, we're suctioning his airway, we're trying to oxygenate him with a non-rebreather, and his sats continue to plummet. We hit him with intranasal Versed, nothing at all. Didn't even put a speed bump in his seizures. We do manage to get a line, hit him with Valium, no response. Does absolutely no good. So at this point, obviously his sats are dropping. He continues to be hypoxic. His heart rate's up there. And we have 10 to 15 minutes to the hospital. Not ideal by any means for an airway and respiratory point of view. He's right at that clinical cliff. And what you do next really could make the determination on whether he lives or dies. And, I'm not saying that very dramatically, but a misstep could push him over the cliff. Failure to act, he'll continue to desaturate. He'll continue to become more hypoxic, more acidotic, more hypercarbic, and jump over the cliff himself. So not doing anything isn't an option. And so that's what we're looking at. And the key thing here is the desaturation issue, which is what we're going to talk about. Obviously, RSI in this guy, which is probably the definitive action, RSI in this guy, stopping the seizures, start oxygenating and ventilating, blowing off the CO2, stopping the muscle activity so that he starts off radiating his heat and cooling down. All those would be ideal, except for the fact that when you look at his neck, you see signs that you might get into trouble and be faced with a can't intubate situation, possibly can't ventilate situation. Big red flag. Secondary consideration, of course, we're considering how hypoxic, hypercarbic, and acidotic he is. You're not really sure if he's going to tolerate the induction agents. Sometimes that alone can push him over the cliff. That's a different story. We'll talk about that. So, but what we're talking about today is desaturation. Now, when you look at desaturation, obviously hypoxemia is bad. Okay, everybody knows that. Oxygen good, no oxygen bad. But in the setting of airway management and resuscitation, we know that when you go into an RSI, when you go into an advanced airway maneuver, that if you go into it with a poorly oxygenated patient, your chance of adverse outcomes increase significantly. Those adverse outcomes are bradycardia, cardiovascular collapse, hypotension, and of course cardiac arrest. Whether if you go into the situation with a good preoxygenation, with their sats in the mid to high 90s, everything else is well controlled, the incidence of those events go down significantly. Now, obviously that's a very simplistic deal when you look at all the things that go wrong in advanced airway management. Obesity plays a role, their overall health plays a role, And number of ET attempts plays a huge role. That's another story for another time. That's why it's important to get your first pass success. But their oxygen saturation, their PaO2 going into the advanced airway on the front end has a definite correlation to how well they're going to tolerate it and what's going to happen on the other end. So this graph, we have the oxygen desaturation curve. And if we look right here, here's 100% SpO2, and this is their approximate PaO2, arterial oxygen, what we see on the blood gases. Now, for those of you who may not be completely familiar with the difference, SpO2 is always a percentage of hemoglobin bound up. So you will never have more than 100% SpO2. I know I have some students out there who love the extra credit, be like, but Steve, can I get an extra percentage point? No. Pulse oximetry is a percentage all the time. Your PaO2, however, is not a percentage. It's millimeters of mercury. It's a pressure reading of oxygen in the arterial bloodstream. It would be different if it's in the venous bloodstream. And our normal range for that, of course, if you're familiar with ABGs, is 80 to 100 millimeters of mercury. But if you have somebody you've over-oxygenated or pre-oxygenated or hyper-oxygenated, whatever term you want to do, you can certainly have readings above 100. You can have them into 200, 300, 400 even sometimes quite easily with an advanced airway in place. So when you look at this is the oxygen desaturation curve. Now something that is really important for you to note is that when you look right across here, say this is about 90%, and you bring this line straight across here and bring it right to, if you look where 90 comes across, and then you'll see 90 is roughly equivalent. 90 is roughly equivalent to about 70 to 80 PaO2. Now this has an effect on whether you're hypothermic, normothermic, or hyperthermic. That has an effect on this that can shift this one way or the other. But generally about 90-93% is where we start breaching into hypoxia in the arterial blood gas. And if you notice, 80%, I mean, we don't think of 80% as that bad. Sometimes in the COPD years and stuff like that, 80% is still, I think, B on your academic scores. But 80% for here is a PaO2 of about 40 to 45. And you can see how it rapidly drops off. Now, this is a graphic from an article which will be actually available at the end of the presentation by Scott Wingart and Dr. Levitan, and shows that associates risk of adverse events during advanced airway maneuvers based on the oxygenation they have going into it. So you can see above with a PaO2 above 90, with a SpO2 above about 94, 95, relatively low risk if everything else looks okay. But once you start getting below that, you start getting high risk, and then you start getting the hypoxemic. And when you get to the hypoxemic level, you're already way behind the 8 ball. So anyway, there we go. Beat that horse to death. This is why preoxygenation is so important in the advanced airway management. Now, we always think, okay, we want to buy them a little bit of time to perform the intubation attempt or drop the supraglottic air or whatever, and that's true. But the thing that preoxygenation really does for us is it helps prevent adverse events before they happen. Now, normally, proper preoxygenation takes between 2 to 3 minutes of full tidal volume breaths, normal breathing. So if they're agonal breathing, that's not a tidal volume breath. A full tidal volume breath, either with the patient taking good, strong respirations or us bagging them. And you think, well, if they're taking good, strong respirations, why are we doing advanced airway management to begin with? Well, there's a number of reasons. Burns and impending failure, but they have, stuff like that. But the bottom line is, most of the time, we're going to have to do this for them. We're going to have to preoxygenate 2 to 3 minutes. Now, I want to put a little comment out there on preoxygenation in that when you do that, you want it to be slow, gentle ventilations. I know it seems like an oxymoron, slow, gentle, but good tidal volume. You don't want to overventilate them because any excess air goes into their stomach, and if you're ventilating that way for over 2 minutes, You can hyperinflate the stomach, cause gastric tension, and then there'll be the technicolor vomit cannon. And that's no fun. Now, there's 3 ways that preoxygenation helps us. And the first 2 ways you see under nitrogen washout. Now, if you think back to the atmosphere we breathe in, the atmosphere we breathe in is only about 23%, 22, 21% oxygen. And the rest is other inert gases, the majority of which is nitrogen. Now, about this time you're watching this, the inversion will probably set in Boise and Meridian, and you'll probably be thinking that the ambient oxygen concentration is probably about 15%. But normally it's about 21, 22%, and the rest of it's nitrogen. If we look at the dead air space and we can take the nitrogen that's in the dead air space being from the tip of our mouth down to the alveoli, the highway to the alveoli, take all the nitrogen out of that and replace that with extra oxygen. That's like a reserve. That's like a reservoir. Just like the reservoir on your bag valve mask, reservoir on the end of your non-rebreather, that's a reservoir that the body can continue to use even if it's not mechanically breathing. Now, the second bit of nitrogen washout is in the bloodstream. Now, obviously, we think about the red blood cells carrying oxygen back and forth, and they have, 4 oxygen molecules for every hemoglobin molecule, so on and so forth. What people don't always realize is that there's a small component of oxygen in the plasma, just free floating around. And there's some nitrogen there, and so on and so forth. So if we can replace that nitrogen with additional oxygen, again, that's more oxygen available as a reservoir. Now, by comparison, about 90% of the nitrogen is going to be in the dead air space, about 5 to 10% is going to be in the plasma, but every little bit counts when you're oxygen starved. And finally, the third benefit, of course, is increasing the actual arterial blood gas of oxygen and the actual pulse ox, the actual oxygen saturation. We already beat that horse to death. So, even with us doing everything else correctly, the moment the patient stops breathing, the moment air stops going in and out, desaturation can begin to happen. Now, the question is, how quickly does it happen? Now, generally speaking, what we know from several sizable studies is that it depends on the patient. In some patients, it can happen as easily as 2 to 3 minutes, and other patients up to 8 minutes. And there's a lot of things that have to do with that. Their clinical status, their shock state, and a big one is obesity. And we know that for the morbidly obese, say 250 pounds approximately or more, they can, despite doing everything right, they can desaturate in about 2 minutes or less. And that's with preoxygenation. So if you don't preoxygenate them, we're talking desaturation in 30 seconds or even less like that. And desaturation is defined as the alveolar oxygen saturation of about 87%. Other things can affect this, your cardiac output, whether you're septic, whether you're volume depleted, pulmonary blood flow, so on and so forth. A normal, healthy person, not that we see those very often, a normal, healthy person with good physiology walking into the OR with picture-perfect preoxygenation for about 2 to 3 minutes in a controlled environment can usually maintain their saturation up until about 8 minutes or so. We just don't always see those guys. So the key point from that little graphic and that little discussion is that if patients have not achieved a pre-intubation pulse oximetry of 93-95%, their chance of desaturation and all the bad stuff that happens with that, the cardiac arrest, the bradycardia, the cardiovascular collapse, increases dramatically. But we also know that, especially in the critically ill, we can't predict reliably who will have sudden desaturation. There are some people that we know will, but even the healthiest person, or what we think are the healthiest person, may also take a crash. Now, the issue has always been, before this no DESAT concept, is that preoxygenation stops when you stop bagging them, or it stops when they stop taking their tidal volume breaths. Until now. And this is the difference with this no desat concept, as simple as it is, than compared to what we've always done before. The idea of no desat is that we can actually continue to pre-oxygenate them, even though there's no mechanical inspiration or exhalation. And we can do that significantly beyond the 3 to 8 minutes we just discussed. Now, this term no desat, it's just like, it's a catchy acronym, similar to like the golden hour was supposed to be catchy, help drill concept in. And a little background, the guy who developed it, Dr. Levitan, Richard Levitan, is pretty much the guru when it comes to advanced airway management for paramedics and emergency doctors and anesthesiologists and anybody else who gets their big thumb in this mess. If it's had to do with advanced emergency airway management, whether it be surgical crikes, induction agents, RSI, bag valve mask ventilation, face mask seals, there's a good chance somewhere along the chain Dr. Levitan's been involved with it. So Dr. Levitan came up with this phrase, no desat, and it stands for nasal oxygenation during efforts to secure a tube. No desat. So it has some other terms, also known as apniec diffusion, apniec oxygenation, both of which are perfectly appropriate also. So what it is basically taking a traditional nasal cannula and using it in an atypical way to improve oxygenation during apnea or near apnea. You could, now most of the research has been done on this in the setting of, okay, we're about to get an innovation, we're about to get a tube or drop a king or whatever we're about to do. I think personally, looking at the research and wrapping my brain around it, this also has a role in passive oxygenation during cardiac arrest. It has a role in difficult area situations like the case study I opened up with, and we'll talk about what happened at the end of this presentation. Has a role in multiple things around airway management, not just with passing a tube. So the basic concept is you're going to take your nasal cannula, standard nasal cannula, you're going to put it on the patient at 15 or more liters per minute. And this is about the time most people are like, what? Are you smoking dope? Steve, go get a drug test. And well, I probably do need a drug test, but no, I'm not smoking dope, at least not today. I'm on the clock. I save that type of activities till after class. But here, you know, I look at this, and I remember when I first read this, I remember thinking, how many times we walked into the nursing home and we had a chuckle because the nurse had the non-breather or the nasal cannula up at 15 liters per minute, and kind of chuckle about, well, she didn't know what she's doing. Well, little did we know that she's probably helping the patient a lot. So one of the questions is, why does nasal cannula oxygenation work? Why is this equivalent to or better than a non-breather? Well, one of the reasons is that the anatomical structure of the nasopharynx is different than the oropharynx. I mean, that's no brainer. The oropharynx's main job is to shove food in our pie hole, swallow it, and vocalization. Its second or third role is, of course, to assist with oxygenation and ventilation. The nasopharynx's primary job is airflow. So if you have a properly positioned airway, you actually can get as good or better airflow through the nasopharynx than you will through the oropharynx. It's been studied extensively in the anesthesia journals. It's quite interesting. Now, another question is, what constitutes high flow nasal cannula airflow? Well, it depends on the age of the patient. For neonates, the normal range for nasal cannula is 1 to 2 liters per minute. High flow is 3 to 6 liters per minute. For infants and children, we're normally looking at between 2 and 5 liters per minute, where a nasal cannula, a high flow nasal cannula, is going to be between 5 and 20. For adults, nasal cannula oxygenation normally is about 2 to 6 liters per minute, and what we're looking at is 15 or even 30. Now, most of us don't have flow meters that go above 15. Some of them out there go to 25, but generally speaking, more is better in this case. Understanding that you're going to go through your oxygen supply very quick if you have a limited supply, so use common sense. But that's what we're talking about. So, give me a second. So, in the infants, this has even been looked at, and we've seen that high flow oxygenation via nasal cannula has been comparable even to CPAP for these difficult neonates that are having trouble oxygenation. Far better than standard flow nasal cannula. This has been studied, but comparable to CPAP. Now, obviously, there's some things that may or may not have a factor here, but at least 2 different studies have shown this. And when we say better than nasal cannula, standard nasal cannula oxygenation, when we say comparable to CPAP, how do we measure that? Well, they looked at several factors. They looked at whether the heart rate came down. They looked at respiratory rate, work of breathing, pulse oximetry, of course, and the percentage of patients that need being intubated. And across the board, there was an improvement of high flow nasal cannula versus standard flow nasal cannula in the critically ill infants and neonates. And depending on what the pathology was, whether it was helpful with or comparable to CPAP. Now, this was mainly studied in bronchiolitis, croup. It was not studied in asthma or pneumonia, and they used specialized in-hospital humidified and warmed oxygen. So it may not be an apple-to-apple comparison with what we see in the field, and we don't know how well that will work, especially with those with restricted airway flow, such as with asthma, which is where CPAP really does a lot of good. So about this time, you're probably wrapping your brain about this, and you're thinking, well, wait a minute. Eventually, the oxygen in the alveoli is going to be depleted. And without any positive pressure airflow or respiratory motion, respiratory movement, how does the other air get down there? Sure, we wash out all the nitrogen and we replace the dead airspace, which is about 150, 200 cc's usually in the adult male. We replace the dead airspace with extra oxygen, but how does it get down there? Well, this is kind of an interesting concept. And what we found out is that even though oxygenation and ventilation occur at the same time in the same place, side by side, they are 2 separate processes that occur at 2 different rates. So basically, if all of the things being equal, and if we have, and this big if we have good capillary blood flow, CO2 is dumped into the alveolar space at about 10 liters per minute. However, oxygen is taken from the alveolar space at about 250 milliliters a minute. And what that basically means is that with good pulmonary blood flow, with a good alveolar space, with good unrestricted airflow, and everything else being picture perfect in a perfect world, you have a deficit of 240 milliliters a minute, which basically means that you have a drawing effect of air, of oxygen hopefully, down the airways, down the bronchioles, down the bronchi, down the trachea, into the alveolar space by this deficit. Now, obviously, I think I've stressed the fact that a lot of things go into this. But this is one reason why we run high flow nasal cannula, high flow nasal cannula oxygenation in this situation, is to facilitate this airflow. You can get some of this with a non-rebreather, but the issue is A, you get better airflow, better passage of air through the nasopharynx, and B, you don't retain CO2. That's one of the biggest problems with non-rebreathers, traditional non-rebreathers like we use here in the States, is that they actually help retain CO2. If you look at a non-rebreather running at 15-20 liters per minute, the airflow is actually a little bit insufficient for most normal tidal volume, and you have some CO2 taking up space in this mass that you're breathing in, or whatever CO2 you're exhaling, and that lowers the inspired fraction of oxygen that you're going to be taking in. You don't have that problem with nasal cannulas. Now, there are some specialized non-rebreathers that eliminate this. The one that comes to mind is the oxy mask, but they're not in common use everywhere. The traditional non-rebreathers have some issues with that. But anyway, so that's how the airflow works. Now, the question is, how long can this be done? Well, it has been studied in healthy adults, and they've been able to paralyze these healthy adults, monitor them, draw blood gases, the whole bit, and they have been able to keep these patients oxygenated up to 100 minutes. I want to say that again. In the healthy adult, they've been able to oxygenate them well up to 100 minutes. These are healthy patients that they paralyzed and did this on. Now, I don't know who would volunteer for this situation. You know, I know that you like to breathe, but we're going to take that away, and we're just going to oxygenate you without any respiratory motion, but let you be paralyzed for 100 minutes. I hope they paid those volunteers well. But anyway, so that says this can be done. Now, at that point, you start, after 100 minutes, you start worried about the buildup of carbon dioxide. And these were healthy patients that were not producing a lot of carbon dioxide because they were paralyzed, and therefore they didn't have a lot of muscle activity. This is not always the case with us. Oftentimes, the patients we receive are already hypercarbic going into it, so that's a concern. And in the case of the case study that I led in this presentation with, that guy is clearly hypercarbic because he's hyperthermic. He's been seizing for 4 hours, so on and so forth. So it doesn't necessarily apply 100% to what we see in the field, but does tell us that the potential for this is substantial, far better than the 3 to 8 minutes that we have on the best day with normal preoxygenation. Now, will it work every time? Absolutely not. One of the key things that this depends on is good pulmonary capillary blood flow. If you don't have a good pulmonary capillary blood flow for the gas exchange, this isn't going to work. If you have if you have mismatch of oxygenated versus disoxygenated blood, if you have, like, say, a patent foramen ovale, a patent ductus arteriosus, PDA, which up to 25% of people might, these are all going to be problems. Still, this is a useful tool for us in the emergency setting, and it's very low tech, very easy to do. Just it doesn't always work. Now, some things that you can do to improve the no DESAT concept. First of all, head position. The studies that I mentioned, that there have been some studies that have looked at oxygenation in different head positions. The sniffing position, which is what we normally do. The elevated head position, which is what we normally do in preparation for intubation, or we should be doing, is ideal for this. So basically, you want the corner of the ear elevated through pillows behind the head to about the level of the sternal notch, just like you would in preparation for intubation. That is ideal. You want a clear, uncompromised nasal passage. Take a physical assessment of that. Some people, when they do this, will drop 1 or 2 MPAs and run it through that just for non-turbulent airflow. And we also want airflow rates above 15 liters per minute. As fast as you feel is appropriate based on your current oxygen supply. Obviously, it does you no good if halfway through your intubation attempt you run out of oxygen. And this has also been combined very successfully with non-invasive positive pressure ventilation. You're, wait a minute, you're probably going, well, if we're bagging a patient, why bother? Well, sometimes what will happen is when you're bagging a patient, your face mask seal isn't ideal. Sometimes when you're bagging this patient, you'll have some mismatch of ambient air. This compensates for that, presuming that you can still get face mask seal. Ideally, you have good face mask seal. If your mask is in good shape, you can easily bag the patient with the nasal cannula in place. I've done it, but it's a judgment call. So what uses do we have for this in EMS? Well, the biggest one is a tool to oxygenation, pre-oxygenation during RSI to avoid problems to begin with. We know that pre-oxygenation extends what we call the safe apnea period, the amount of time a patient can go without taking a breath or being given a breath before they desaturate, and that's that 3 to 8 minute period. How long we prolong it, again, as we've shown, it really depends on their overall health. If you get into a fur ball with the airway, this gives you time to figure it out. This might buy you time to solve the problem so you don't have to do something very dramatic such as crackle. And it also might help avoid the can't intubate, can't ventilate situation altogether. Again, every case you meet is going to be different. Every RSI is different. And when you get into the difficult airway, there is no one-size-fits-all solution. But this is a really low-tech, very useful tool to have in your oh crap toolbox. So here we talk about the head position. There's an example. You will see right here the guy has a non-rebreather on. It's running. He has a nasal cannula in place, and he also has nasopharyngeal airways in preparation for oxygenation. And I believe this was actually an actual patient whose BA was somewhere north of 3 or 4 times, if I recall correctly, his what would be ideal, and just due to alcohol intoxication had to be intubated. And there he is during the intubation attempt, doing quite well, and his safe apnea period was prolonged, and they were able to take their time when they went in and intubate him on the first attempt, which is what all of us want in an emergency setting, is somebody to take the stress out of it, to buy us some breathing room, no pun intended, some breathing room to solve the problems that are going to pop up. So when we wrapping it up, this no DESAT concept is just one method to provide better oxygenation before and during advanced airway management. It's not a solution to every problem you're going to encounter, but it's low tech, it's easy, and every ambulance has this capability. Every BLS engine company, QRU, has this capability. For you guys on the BLS side of things, where you have not all the tools we have to manage difficult airway, if you can't get a face mask seal, if you have a patient who, due to position, you can't bag them, whatever, this might be an option, either by itself or in addition to everything else you're doing. So, very useful. I hope you guys learned from quite a lot from this. Now, at this point, you're saying, okay, that's great, Steve, but how about that guy? How did that seizure patient turn out? Well, we were transporting him and he continued to desaturate. The Valium was ineffective. The Versed was ineffective. He had multiple red flags for difficult airway, and his SATs now are in the low 70s, high 60s, and dropping. At this point, this is a crash airway situation. It's going to be bad. I think we had to do an IO on him, if I remember, just to get vascular access. So drawn up our medications and everything. We're trying, and just, you know, I knew in my gut this was going to be a difficult tube. On the best of days, possibly could even end up having to crack this guy. I was very worried about it. But in anticipation of setting everything up and being aware of this concept, I threw him on the nasal cannula. Now remember, his SATs were in the 60s, 70s. We already had a non-rebreather on him running at a high rate. We'd already tried bagging him. We were suctioning him, so on and so forth. It wasn't working. Threw him on the nasal cannula, and within 2 minutes, his SATs rose to the mid-90s, and by the time we got to the hospital, his SpO2 was 98 to 99%, with the nasal cannula on 15 liters per minute, with him still in active seizure, with him still having airway problems. Now what this did, and his heart rate came down in a good way, not in a bad way, not in a bad way like dropped to 60, but good way as in dropped to down to the 110s. Oxygenation came up, completely changed the urgency of this situation. I'm not saying it wasn't a dire situation, but now instead of having to get a tube in the next 2 codes, now we have time to use some better, more appropriate techniques. So at this point, his airway's still dubious. He still has some clenching of the jaw. He still has secretions and blood, but we're able to manage that with simple suctioning and recovery position. We're in a lot different position than we were just 2 minutes before I put the nasal cannula on. So we let the hospital know what's going on. We painted a pretty good picture. We rolled into the main resuscitation room of the hospital. The ER doc was there. He had the glide scope there. The whole team was there. They actually listened to us. And he was intubated. He was intubated, I want to say, on the 3rd attempt with the glide scope. And what that tells me, watching it and seeing the doctor's difficulties with the glide scope, is that this would have been an exceptionally difficult airway without it. It was a difficult airway with the glide scope. Reasonably assured that's going to be even more complex without it. So anticipating the difficult airway was logical and accurate. And the use of the high flow nasal cannula prevented us from getting into a nasty furball at the airway, bought us time to where he could be intubated under more controlled situations. Now, I hope this was useful. I hope the case study was useful. If you have any questions, we'll make this presentation available. There are some articles on NO DESAT, including some that explain it way more eloquently and simply than I just did. So I hope it's useful. And here at Ada County and the JPA, we hope you enjoyed this. Thank you.